So HCC is a unique cancer. I think both medical oncologists, surgeons, and hepatologists agree on this point in that it not only needs to address the stage of cancer, the extent of cancer, and the burden that cancer brings on the patient and the caregiver, but also needs to very carefully assess the burden of liver disease, which is a competing risk for morbidity and death. And so it is critically important that we have an effective multidisciplinary team that has the expertise and the breadth of knowledge to address all these issues in one patient. So invariably, in most settings of care, especially where HCC is a focus and an area of expertise, a multidisciplinary team would include a medical oncologist, a hepatologist, a surgeon, typically a hepatobiliary surgeon, and sometimes that person doubles up as a transplant surgeon. Ideally, it would be highly desirable to have a radiation oncologist, a pathologist to review any pathological findings, a survivorship person, and a tumor board navigator. All of these folks are very important in ensuring that care is consistent, is thorough, and enables the patient to benefit from the best outcome possible. One critically important issue in a patient with HCC is our ability to maintain good liver function, which would in turn enable the patient to navigate hopefully one or more lines of therapy and benefit in terms of survival and hopefully quality of life. This requires a fairly typical workup at the outset, which includes a workup for liver function with what we call the MELD score. That's a score that factors in both the coagulation profile, the INR, the creatinine, which is kidney function, which often deteriorates in people with advanced liver disease, and the bilirubin, which is a reflection of liver function. It is important to stage disease frequently to assess any response to therapy in addition to a baseline. This is typically done through dynamic imaging. At some centers, CT scan with portal venous phase is the main expertise, and that's perfectly appropriate for baseline and follow-up. At other centers, an MRI with gadolinium, with and without gadolinium, is the way to go, as is the case at our center. But certainly dynamic imaging over time is very important. The interval of imaging is somewhat debatable, although in any person who is actively pursuing treatment, an interval of anywhere between 8 to 12 weeks, I think, is a very reasonable time frame to follow up, because we definitely need to know if the patient is experiencing progression of disease. And we also want to know if the patient is responding adequately to therapy, because that provides reassurance that we're on the right track, and also great encouragement for the patient in knowing that they are able to hopefully benefit from the treatment that we are offering them. I think it is important to understand that while we may need to pursue a liver biopsy in some patients, this is only a very small number of patients who have a presenting picture of cirrhosis and a liver lesion that meets imaging criteria for HCC. There's a number of societies that have put up criteria for what determines a diagnosis of HCC in a patient with cirrhosis with a high degree of certainty. And so I would say that in a setting such as ours, of every 100 patients with HCC, we might have to biopsy less than 10 of them in order to confirm a diagnosis. Of course, when the imaging does not exactly meet the criteria, enhancement and rapid washout, capsule formation, the so-called LIRAD score, when that is certainly less than 4, one would indeed recommend the biopsy. But as I said, this is really not a common thing, and definitely would want to avoid it to the greatest extent possible in most patients.